Perfect. Well, thank you guys so much for having me here today. I'm excited to talk with you today about midwifery, and I just have to figure out. Oh, there we go. Okay, so my name is Jenny Ramsey. I'm a certified nurse midwife. I work for M Health Fairview at the Riverside Clinic, and I am also a Menopause Society certified provider and have been doing a lot of menopause care for people without a history of breast cancer, certainly, but then more and more I've had people coming with a history of breast cancer as well. So our objectives for our time together, what I'm hopeful for is to kind of go through and so that to help people understand why menopause after cancer and cancer treatment is different than the process of natural aging, and then also to provide some tools and toolkit for you for coping with that on the other side. So there are over 4 million breast cancer survivors in the United States, and this is a number that's growing. We're getting better and better at managing and treating breast cancer. But in that, then, there's a lot of times where the breast cancer treatment will throw people into menopause. And there is Dani Binnington out of the UK. She's the founder of the Menopause and Cancer organization. And I really like her quote, just because I think that it helps capture and articulate it a little bit better. But, you know, doctors will often tell you that HRT isn't an option, depending on the kind of cancer you had. So you're left on your own, dealing with the double whammy of menopause symptoms, and then the trauma and loneliness and anxiety that can follow cancer treatment. So menopause after cancer really is the hidden menopause. And so that's why that's the name of this. Overall, 88% of cancer survivors feel like they did not receive adequate support about menopause, about what it means for you, about how to cope with it, and what are some of the options for management. I also think that just overall within our society, that there's a lack of recognition of the full impact that this can have on your life and your quality of life. And so I'm really excited to be here today because I'm hopeful that we can change that. So why is menopause after breast cancer different? So natural menopause is the result of normal aging, and it can be challenging in its own right. I have full clinic days filled with people struggling in perimenopause and menopause without a history of breast cancer that are looking for help. But typically, as people age through perimenopause and menopause, there's a little more somewhat gradual decrease in the estrogen and progesterone in the body. We all know the common symptoms, you know, the hot flashes, the night sweats, the joint and muscle pain, fatigue, mood swings, brain fog, dry, irritated vagina, insomnia, and the list goes on and on. The reason for that is that there are estrogen receptors in every organ of the body. And so as those levels decrease, then it affects every organ. And everybody feels it different, and their experience is different. So menopause induced by cancer treatments, especially in younger people, is often much more abrupt. And it's also very often more severe and complex than those who go through menopause as part of natural aging. There are additional challenges to treating menopause induced by cancer treatments. So menopause treatment is often, it's going to be much more nuanced and complex after cancer. And to be frank, there are not a lot of people that are trained and across oncology and menopause specialists. And so there's a bit of a vacuum or a gap in that. And then the other thing that I don't know how well this gets looked at, but just managing some of the long-term health risks needs to be considered, because estrogen and progesterone are hormones in the body that actually are very protective for a lot of a person's life. And then when you don't have that, then how do you manage the after effects? So each person's breast cancer is as unique as their fingerprint, and so must be their menopause management, for sure. All right, so just so we're all on the same page, and my guess is that you guys are very familiar with this. I just want to make sure that we're talking about the same thing, but breast cancer treatments. So surgical menopause just means having your ovaries removed, and it's called an oophorectomy. If both are removed, it's called bilateral. Bilateral just means both sides. The ovaries are the main producers of estrogen and progesterone, and removing them causes an abrupt stop to the body's production of those two hormones. And so then there's often immediate and pretty severe menopausal symptoms after that. There's also, some people are treated with chemotherapy. Some chemotherapy medications can cause damage to the ovaries, and this can decrease or stop the production of estrogen and progesterone in the ovaries. And these changes can be temporary or permanent. And then finally, this huge group of treatment modality, hormone or endocrine therapy. And so I think of this group as anti-estrogen medications, and it causes a chemical menopause. And so the three main types are going to be tamoxifen, ovarian suppression, or aromatase inhibitors. So tamoxifen is a SERM, which is a acronym for selective estrogen receptor modulator. So many breast cancers are often estrogen receptor positive. That means that the estrogen stimulates the cancer to grow. And what tamoxifen does is it blocks the estrogen circulating in your body from getting to those cancer cells. So it's not necessarily decreasing the amount of estrogen in your body, but what it's doing is it's blocking it from working. When it does that, it's protecting those cancer cells from getting stimulated by the estrogen, but it also can block it from working in other parts of the body, and so can indeed also cause menopause symptoms. Ovarian suppression. So when you think about it, the ovaries are the main producers of estrogen and progesterone, and these medications turn the ovaries off. They make them stop producing estrogen and progesterone. And then finally, the aromatase inhibitors. So most of the estrogen is made in people's ovaries, estrogen and progesterone, but a small amount gets made in the body fat. It becomes more prevalent after somebody goes through menopause, and the ovaries aren't kicking as much. And so this process involves an enzyme, which is just a fancy word for protein, that's called aromatase. Aromatase inhibitors stop this process from working. So if you have ovarian suppression, you're turning off the ovaries, you're reducing estrogen that way. If you use an aromatase inhibitor, you are also stopping the production of estrogen that happens in the fat. And so in premenopausal women who still have their ovaries, one or both, then AIs may be used with ovarian suppression at the same time. And what this does is it really drives the level of estrogen in your body down. So then when we talk about symptoms of menopause, the thing is that sometimes it's hard to tell which came first. Is it your cancer treatment, or is it menopause type stuff? Because they look very similar. So is it chemo brain? Is it menopause brain fog? Are you suffering with anxiety because you've been diagnosed with cancer? Or do you have more anxiety because you've got lower hormones? Do you have more anxiety because you're not sleeping? And you're not sleeping because, and it's hard to tease out, and the list kind of goes on. One thing that can be helpful, and especially as you're communicating, just tracking your own symptoms and then also being able to communicate with your healthcare providers, is accessing some sort of a symptom tracker. And there's all sorts of them online. It's a great communication tool. It also helps it helps articulate your experience into words. And so it works that way. The other thing is, if you're looking at interventions, you can use it to help, say, oh yeah, well, before I started doing this, I was having this many night sweats, or I was having, and then you can actually see, oh, well, instead of 5 a day, now I'm having 2, and like that. So this is one I particularly like, and I'll show you how to get it later. It's from the Menopause and Cancer, and that's from that Danny Vinnington's organization, and it's downloadable. And what I like about this one is it also has a separate section for genital urinary syndrome type symptoms. So now next we're going to switch gears, and we're going to go into our second objective point and talk a little bit about Menopause and Cancer Toolkit. One of the first things I want to hit is the non-hormonal prescription treatments.
The night before she had.
I don't know. All right. So non-hormonal prescription therapies. Now, all of the guidelines out there from both the menopause side of things and the oncology side of things will recommend non-hormonal therapies first. And that's because they're considered safer than systemic hormonal options for people with a history of breast cancer. So the Menopause Society is another great place for resources. This is how you get to their Meno note on it. So they have a very nice research-based list of things that have stood up in randomized controlled trials across the board to be effective in helping manage menopause symptoms. So if you can Google Menopause Society. They have a patient resources tab. Down there you can get to Meno Notes. And then Meno Notes actually has a whole list of links and things that you can look at. And there are more that have to do with people with a cancer history. But the one specifically that I am referring to is called, just so I get this right, non-hormone treatments. So this is the one, this is what it looks like. And actually, I use this a lot in my office for people with with a history of breast cancer and people without. This is what they are. So typically cognitive behavioral therapy, clinical hypnosis. I pulled out SSRI just because I wanted to mention, most of you probably know this, but you can't take Paxil if you're taking tamoxifen because of the way they interact in the liver. And I'm hopeful that you're working like with a medical pharmacologist or pharmacy person, so that anytime if you are thinking about adding a medication, it's a good idea to run it by them first. And from a provider standpoint, to be perfectly honest, we don't always know about every medication interaction and side effect. Well, side effects we do. But the thing is there's also just so much coming out as far as the different pathways in the liver, and it's a very evolving thing. So I always recommend before you start a new med from somebody, please check it against your pharmacist. Gabapentin, weight loss, fezolinetant, and then there is this one, it's new, it's elalinetant, I'm still learning how to say it, otherwise it's called Linquet, and it came out late last year, and it works in a different way, in a specific way to block the hormones, or to block the hot flashes and night sweats in your brain before it gets to the temperature regulation center. So it's not hormonal, but it has been shown to be as effective as estrogen in helping with the vasomotor symptoms. The other thing about it is that it also has shown some benefit with sleep, and they have a small trial of people with breast cancer survivors as well. So it's also brand new. It's super expensive. And so, you know, as life goes. But because it's new right now, there's also a lot of programs out that you can get, you know, coupons for 12 months, that type of thing, where it, and there's different programs like that to help you get it covered. So now I want to talk about hormone treatment options. So first, I just want to start with some basic definitions. What do we mean by hormone therapy? We are replacing what the ovaries make, typically the estrogen, progesterone, and testosterone. These two terms are used interchangeably. HRT, which is hormone replacement therapy, and MHT, menopause hormone therapy. Now there's two ways to take hormone therapy. Systemic, so you're taking it so that it increases the amount of estrogen and or progesterone that's in your whole blood, circulating in your bloodstream. Or there's local, which is very targeted. It's right to one area. Typically, we're talking about the genitals, and it is not increasing your systemic or your circulating blood level of estrogen. So the thing about hormone therapy is that there is I'm sure everybody here is aware, that there's a history for everyone. Those even those without a history of breast cancer, that is very complicated and it's filled with a lot of controversy. And so you're going to hear a lot of different things from different places. And for those people with a history of breast cancer, the decision to take systemic menopause hormone therapy is even more nuanced and complex. But I'm hopeful that I can give you some tools to be able to start understanding how to tease out some of the risks and benefits for you and how to be able to advocate for yourself. So first and foremost, this is a team sport. Whoever you are seeing for your menopause symptoms needs to be consulting with your oncology team. And just in my own personal practice and experience, I have found the oncologists to be really receptive. And I don't know how many of you come through the U or not, but I work for M Health Fairview. And so that's typically a lot of the people that I end up working with, but they respond to consultation notes really, really well and fast. But things that I want you to think about in that is you need to figure out the risk of recurrence for you specifically. And this is going to be so different for everybody. This is where we're really talking about how everybody's breast cancer is different, their treatment journey is different, and so their risk of recurrence is different for each person, and it needs to be personalized. And then you also need somebody to sit down and explain to you the evidence that we do have on the risks and benefits of taking hormones after breast cancer and the limitations of it. We don't have a lot of great like randomized controlled trials, and that's another part of the problem. We have a lot of observational studies, but I think that this isn't a passive activity, to be perfectly honest. And I'm sorry that this ends up being another thing on your checklist that you would have to engage in and do, but it is very much a partnered activity between your practitioner and you deciding, because nobody else can decide for you what you're weighing the quality of your life and what your symptoms are against your risk of recurrence, because we don't know who's going to have recurrence or not. And then the other thing that anybody you're talking to about menopause should also cover with you is, have you tried non-hormonal options to help cope with your symptoms? So my cautions in this is that compounded hormones are not safer. They are usually less safe because there is less FDA regulation to them. And the word bioidentical does not mean safer. There are some advantages to some of the bioidenticals, but what bioidentical really means is that it's the same chemical compound that your ovaries make. Right now, bioidentical is being used as a huge, it's a marketing term. There isn't necessarily even a definition to it. So if you see something online that says that, it does not mean that it's safer. And then the other thing is, if you are seeking menopause care, like from an outside clinic, or there's a lot of online clinics now, please be sure to disclose your breast cancer history. Now, I've had a couple of people that I know of that have been feeling desperate, and they've been watching a lot of YouTube, a lot of TikTok, that kind of thing, and thinking that the answer for me and my problems is hormones, and nobody will give me hormones. Nobody even talked to me about it. And so then they go on one of these online clinics and they don't tell them that they have a history of breast cancer. And my concern for that is that certainly you deserve the right to have somebody have a conversation, and a real conversation about risks and benefits, not just it's not safe for you, you had breast cancer. But it also, at the same time, when you do something like that, you don't have enough of the information, I feel like, to make a good decision for yourself. And so those are my main cautions. So before starting systemic menopause hormone therapy, your provider should have a very detailed intake. Your health history, they should want to know your health history, your symptom tracker, but then also they should want to know your very detailed breast cancer journey, because you're going to need the stage, the grade, the type, the lymph node involvement, receptor status, and then if you have like an OncoScore or a MammaPrint, that's helpful, treatment course, remission status, and they should need to know the name and contact information from your oncology team, because that's going to be key also, as they, like I said, they need to work with your oncology team. Two, they should review and discuss non-hormonal options with you to see if we can find some real life solutions that help you feel like you are getting your life back. They should be able to, somebody, whether it be your oncology team or your menopause team, calculate your risk of recurrence. So at the 2025 ASCO annual meeting, they presented the soft and text trials, which are following breast cancer survivors now out 15 years and how they were treated, like with their adjuvant hormone therapy and all that kind of stuff, which is really exciting because this is guiding a lot of the treatment regimens and recommendations right now. And it also powers some of the risk of recurrence tools that we have online. And you totally can ask your oncologist, do the recent results from the soft and text trials relate to me at all? Can we go through any of that? The person you're seeing, before you start thinking about doing systemic hormone therapy, you also want to review the current evidence and the limitations with you. The main trials right now that we have are going to be the Habits, Liberate, and Stockholm. I just want you to have access to those names. And then there's a lot of observational studies also, and a plethora, not a plethora, but there are observational studies as well. And like I said before, this is not one and done. This is a journey, and this is a partnership with your provider. So I do want to, let's talk about the vagina and local estrogen therapy. So genital urinary syndrome of menopause, or GSM, is a real thing. And it includes usually the vulva, the vagina, bladder, urethra, the urinary things. So symptoms can be dryness, itching, irritation, and irritation with activities such as sitting down or with exercise. And certainly with sex, that's a whole different kind of ballgame. It can be pain, it can be change in discharge. It can also be bladder and urinary symptoms, feeling like you have to spend all night getting up to pee, that kind of thing. Over 80% of women report vaginal dryness. This is really a common thing. And it's intimate and it's personal, and sometimes it's really hard to bring up. Just know from a provider standpoint that this is something we talk to people all the time about. And so from our perspective, but because of that embarrassment, many people suffer in silence. And so sometimes if you go back to your symptom tracker, and why I like that menopause and cancer one has a specific category that goes through all of the GSM type symptoms. And sometimes that can be a good communication tool. Like if you don't want to say it out loud, you can even just bring that in and point to it, and say, can we talk about this? So treatments for GSM. So local low dose vaginal estrogen therapy, which I'm going to cover a little more here. A little bit later in the morning, we have somebody that's going to cover more the non-hormonal therapies of lubricants and moisturizers and dilators and that sort of thing. So local low dose vaginal estrogen. We're talking about very minimal systemic uptake. So very minimal, if any, is circulating through your blood. It's targeted. It's right to the vulva, the vagina, and the urethra area. And I would say that the pendulum is swinging, where this is generally being considered safe for breast cancer survivors. And there's statements from the Menopause Society, from the American Urinary Association, the International Consultation of Sexual Medicine, from ACOG, in support of this. And if you are getting if this is something that you are interested in and you're getting pushback from your providers, I do have kind of a list of resources that are the studies, that are the statements from the various associations and that kind of thing, that can sometimes be helpful. Because, like I said, this is a very fast evolving field, and sometimes it just takes a little while to change things. But the other thing about it is it's not just about sex. I mean, sex is its own thing and has its own importance or not for each person, but it's about genital health maintenance. And so it's about preventing vaginal infections, urinary tract infections. It's about being able to tolerate a speculum exam, a pelvic exam, about being able to sit, about being able to exercise and just do all of those things. And the thing is that particularly, well, for anybody, once you start losing that estrogen, then those tissues get much drier. So here is kind of a pictorial of what happens. So when somebody has their estrogen, then the vaginal lining is thick and moist, and they've got good blood flow. There's a lot of elasticity and fluid. Once you lose that estrogen, then the vaginal lining becomes much more thin and dry. You lose blood flow, lose elasticity, and it. So I've had people come to me years after their breast cancer treatment or years after menopause, and they're wanting to reengage in sex, and there has been structural changes to the vagina and the labia, and the vaginal opening gets smaller, and so I really, I think that there's a push to really talk about this as being genital health maintenance more than anything. And it is easier to start at the beginning of this as prevention than it is to come in afterwards and say, and try to treat it after some of these physical and architectural changes have already occurred. So local low dose vaginal estrogen, there's tablets, there's vaginal inserts, there's creams, and there's low dose vaginal rings. And so I'm just gonna kind of leave it at that. So now when we're talking about, so some of this long-term adjuvant endocrine therapy. So what do you do after your primary breast cancer has been treated? And now there's a lot more recommendations driven by the data out of the soft and text trials about being able to reduce your risk of recurrence. And a lot of times that means then taking some of these hormones for maybe, or hormone blockers for like 5 years or 10 years. And so first and foremost, the best treatment is going to be one that the patient is willing to use, because we know that sometimes these cause such suffering and symptoms that that people are like, yeah, I can't do that anymore. And so before you throw in the towel with that, let's look at, is there a way that we can help help manage some of the symptoms and make this tolerable for you, if it's going to make a difference in your whether or not you're going to be at risk for more recurrence. So one of the first things is, how important is the adjuvant endocrine therapy for you? So we have these models now that we run on the computer, where we plug in all of your data about your treatment course and that kind of thing. And you can see, is it like if you take this for 5 more, like you do your 5 years, and then you're trying to decide if you should do 5 more years for like a total of 10. Is it going to reduce your risk like 1 out of 100? 5 out of 100? Those numbers are different for everybody, and each person has their own idea of what's worth it. Is one less case of recurrence, is that important to you? Or is it like, this is really not making me feel good, I want to get off? And so it's a personal decision that you make with your oncology team about that. So if you've decided that the adjuvant endocrine therapy is for you, and you are really struggling with some of the symptoms, here are some of the things that we can do. Find ways to cope with the other symptoms. Can we look at any of the non-hormonal prescription therapies? Can we look at any of the lifestyle stuff? Can we look at other ways to support you? And also talk to your oncology team. They can't help you if you don't tell them what's going on and what you're experiencing. And there's also this, I always think of this when I'm talking with people too, is that there's this tendency for a lot of people to come in and go, yep, it's fine, you know, because you want to be a good patient and you want, you know, and all that kind of stuff. And if there is something that you are struggling with, please tell your oncology team. So it could be that these are some of the things that they may talk to you about. One is taking a drug holiday. And so when you think about a drug holiday, I'm thinking about it stopping the adjuvant endocrine therapy. Sometimes, if you are looking at childbearing, that's not what this talk is about, but they'll have you take a drug holiday to become pregnant and have a baby. Or, you know, so to take 6 to 12 weeks and then make it count. Put an action plan in place. Get some of these lifestyle pillars in place, like work on your sleep, work on your activity, your physical activity, on your diet, that kind of thing, so that when you get to the end of that, then you are a new person. You are in a different spot. And so then, you know, it gives you some of that power and some of that healing back. Sometimes changing to a different aromatase inhibitor can make a really big difference. Sometimes people will change to tamoxifen or stop their ovarian suppression. Sometimes people might reduce their dose of tamoxifen into kind of a little baby dose. So, but the big thing to know is that these are changes that you would make with your oncology team. Your oncology team, they are the captains of the ship. So I can help people advocate for things and ask for things, but definitely the oncology team is the one that's going to make the decision. So managing lifelong health risks. Women treated for early stage breast cancer are more likely to die of cardiovascular disease than of their breast cancer. So, and that is compounded in the younger you are. So lifestyle choices matter. They really do. And if somebody comes to me struggling, and certainly I don't want to just haul out well, if you eat better, you know what I mean? Like, I know that that's not a good lifetime or a good life solution for a lot of people, but there are ways to kind of take a look at it, and it does matter. The American College of Lifestyle Medicine is a great resource. You can partner with a provider and that kind of thing if you're looking for specific counseling or treatment, but then they also have a whole host of habit trackers, of suggestion sheets, of resources too that are free. I want to talk about sleep because that's huge. Improved sleep equals improved everything. Improved sleep improves your life in the present and in the moment. It helps your treatments work better. It's going to help you heal faster, and it's going to help you feel better and just cope with life better. And then over the long term, there are so many downstream effects that improved sleep will help lower your lifetime health risks. And I totally get it. You're like, yeah, great. You know, I would sleep better if I could. So there is, this is a fantastic resource that I have come upon. It's free. You don't have to register for it. It's out of the VA. It's free to everybody. And it is a cognitive behavioral therapy class. And now this is the one intervention for insomnia that has down the line shown to be effective to help with coping with insomnia and reducing it. And so it's a 6-week course. So just be open to it if sleep and insomnia is one of the things that you're struggling with. I do have, and I think it's in your packet, the breast cancer survivor checklist. And so this is things to think about after kind of in your survivorship, and just kind of a checklist to go through as far as managing your health risks. Because as somebody who goes through early menopause, you are indeed at increased risk for a lot of these long-term kind of comorbidities. But at the same time, I really am hopeful that knowledge will help, help empower you then, so that you're certainly not a victim to this. You can make a difference. So knowledge and resources. One of my favorite resources is this Menopause and Cancer. If you haven't come across it yet, it's Danny Bennington, and she's out of the UK. She has a getting started guide. I know that all of this can be so overwhelming at any point that you start looking at the resources and what's a good resource, what's not, that kind of thing. I found that this getting started guide was, it felt very approachable to me. And so, and in that then, so you go to her website, it has under resources, the getting started guide. So then you do have, she will email it to you or email you the link to get into it. This is kind of the first few pages of it. On page 6 is the symptom tracker that you can download and use. She also has, if you prefer podcasts, YouTube videos, she's got a lot of that too, and you can kind of scroll through. Her guests are experts in their field, and she also has a book that I have found to be just a phenomenal resource. So, and then here's another list that I think is in your packet of just overall breast cancer support resources and cancer support resources. So that's it. Thank you so much for your attention. I appreciate it. So I think, I don't know what time it is, but I think I have a few minutes for questions. If anybody has any questions. Yeah. Oh, so it is breast cancer survivorship checklist. Let's see where. So I will ask Liz. Hey Liz, do you know where the breast cancer survivorship checklist is? I mean, I've got it. I can email it out, but okay. So did everybody hear that? Is that she will either print it out and have it available at the front, or she'll email it out. I'm sure you must have all of your email addresses. So yeah, I can't hear. Sorry.
How would you recommend broaching some of these subjects with an oncologist that is a little more rigid about treatment?
I know. And so, you know, I think one of the first things to do is to talk about, share your experience, bring in a symptom tracker is a place to start and say, do you have any thoughts about menopause hormone therapy? Or do you have any thoughts about what can help me here? Or if they have a menopause person that they're working with. I work with the survivorship team here quite a bit, and then there certainly are. So I do also have, like, particularly around the vaginal estrogen, I have a sheet that has all the links and kind of the articles and that kind of stuff, because and sometimes bringing that forward. You know, so I want you to feel like you're being heard by your oncology team. Now, medical oncologists, they're busy, and I know that. And they're they're handling a lot, and they may not have as much time or energy or oomph to do the menopause counseling and that kind of thing. So then I would also recommend, finding somebody that does menopause and breast cancer care. We are trying to come up with so I took a class with Dr. Corinne Men. She is a OBGYN that also does quite a bit of breast cancer type education and that type of thing. And I don't know that it's in place yet, but I'm hopeful that there will be kind of a directory of people that have gotten this further education for that, to give you a little more resources as far as that goes. Does that help? Yeah. So Inter Rosa, yep. So definitely that is also a an option, you know, for sure. And I've had that be successful for some people. Um, and I know that there are also, I don't typically use compounded pharmacies, but I know that there is some people will compound a little bit of estrogen. So we're talking about like a DHEA or a different hormone that is used locally right on the vagina, right in the vagina. It says insert. That provides a little more like, we call it androgens or testosterone to the area, and versus going the estrogen route. And so there are people who will compound a little bit of estrogen, a little bit of the DHA, and testosterone too. But yes, no, so that also can be very effective. Yeah.
How does the hormone replacement therapy relate to the type of hormone positive versus hormone negative cancer that one has
Okay.
that you've experienced?
Yes. Um, so you know, definitely triple negative cancers or breast cancer. That is going to be the first group of people that it would be more probably less risk of recurrence of the estrogen or progesterone causing recurrence. And then you know, then it has so much more to do with when we're talking about positive estrogen or progesterone receptive breast cancers. It depends on so many things as far as your treatment course, your how many lymph nodes, what stage, you know, all of those types of things. And so, how far out you've been in remission, if you've done adjuvant therapy. And so there are online tools. One is called the Predict tool. It's out of Cambridge that that uses that soft and text trial information, and that's part of what we can use for calculating out how likely is it that you're going to get a recurrence. And the thing is these are not they're not perfect, you know, by any rate, and we don't know if you're going to be the one that gets a recurrence or not. And so, but it should be a discussion of you should have information about how likely is it, what does the information we have tell me, and then how weighing that against what your life is, you know, your quality of life at that time. So what's your tolerance of risk compared to you know, how much this is affecting your life. Have you tried everything there is to try? Those types of things. So it's not a simple answer. I wish there was a better answer.
Got one more question over here. Hi, so this was the first time that even the idea of having like separate gynecology care and like oncology care was brought up to me. So I have just been having my oncologist do all of that. And I'm curious like what the necessity is or the recommendation is of like definitely have like two people, you know, view that, or it's like okay to kind of consolidate that, and like
it's totally okay. It's totally okay to consolidate that. But yeah, and if you have somebody that's seeing to this part of it, that is fantastic. That is a winner. But if like the lady behind you, you know, if you're hitting a kind of a little more of a roadblock with an oncology team that is not necessarily broaching into this, then sometimes you do need to seek somebody else as far just to help with education, help with you know, with yeah, you learning what the data is and what the risks are to help you advocate for yourself better. The other thing I was just thinking about as far as dealing with maybe somebody that's a little more rigid is seeing if you can get into like a survivorship program. And because I think that a lot of times that they can be really helpful as far as advocating.
Hi, so am I understanding it right that whether you have symptoms or not, you would recommend doing preventative things for people's genital health for the future?
I would.
Yeah.
Yep.
And could you remind us again, like what those specific things were?
So it's going to be, you know, certainly, I think that Abby's going to do, Ariana, sorry, is going to talk a little more about moisturizers and lubricants, those types of things. If engaging in intercourse also brings blood flow, brings dilation, helps those muscles relax, that type of thing. If you don't have those things going on, then I would recommend talking to somebody about doing a very low dose targeted estrogen therapy.
Yeah, I was wondering what is your experience with like the Mona Lisa treatment at all?
With the what?
Mona Lisa treatment?
I don't have any experience. Is it lasers? Is that what that is?
I think so, yeah.
Okay.
More like to help stimulate the vaginal lining.
Right. And so you know what, I really don't have any experience and with that. And it's not necessarily been covered in the material that I have studied. I know that there's some people who, you know, obviously really, really think that it works well. I would look at the, you know, I would look at the data and the research behind it. It's not necessarily listed one way, you know, like a whole lot in the Menopause Society and that kind of thing. So I'm sorry, I can't speak on that very well.
Fine.
So I just wanted to echo some of what you've said, Jennifer. I'm a triple negative breast cancer survivor and have recently gone through like my own journey of HRT and what that experience has been like. And so for all of you who are like considering it or thinking about it, there's some really great books listed in the back here. Estrogen Matters is great. You're Not Broken. I know you mentioned, I haven't read the other one. The more you can read and just figure out what's right for you and what feels comfortable for you, the easier it is to go into the doctor's office and have that conversation, because they will talk about it, but like you have so much has changed, kind of like you mentioned. Even in the last year, I had talked to my oncologist, or not my oncologist, my gynecologist, and she said, had you come to me a year ago and talked to me about this, I would have said no way. But because there's been so much changing and we're understanding things differently, she was able to let me go on HRT. And again, that was my personal choice, and I weighed a lot of different options, but being educated about it and reading about it and learning about it is going to give you that like ability and confidence to go in and have those conversations. So just wanted to echo that.
Yeah, thank you.
Yeah.
Oh, all right, sounds good. Thank you. Oh,
you mentioned about recurrence, the risk for recurrence in taking HRT. What if you're metastatic? Is it just off the table completely?
so I didn't hear the whole question.
You mentioned that you have to weigh the risks of recurrence to take hormones.
Yeah.
If you're metastatic, is it just off the table, or?
So it's hard to, as far as, I don't like to give any blanket statements one way or the other about whether it's on or off the table. I think it needs a personal nuanced discussion, and certainly that adds complexity to it. But there's so many other factors, like, how long has it been, that you've been in remission, just all sorts of factors in that. But yes, definitely metastatic plays into those risk recurrence tools.
Thank you. Thank you. Thank you for being here. We really appreciate it. I know there were a lot of questions and I appreciate it. If you have other questions, feel free to email us afterwards and we can connect you.